SCB Medical College, Cuttack, and in charge of geriatrics. I am Dr. Pratati Mahanti, Senior Consultant Ophthalmologist from Bhubaneswar. Please come up on the stage.
Calcutta and international member, American College of Gastroenterology, USC. Dr. Ghosh is to tell about the dyspepsia in elderly. Although the attendance is thin because of the heavy rain, till then Dr. Soumik
my respected fellows on stage and in this house and my dear students. Thank you for choosing this topic also. Usually people choose obscure GI bleeding, but this topic is very lucid and easily understandable but difficult to treat. So let's come to the topic. Basically, dyspepsia is a symptom or a problem that is not a disease. What is dyspepsia? Dyspepsia is just a discomfort, bloating, nausea, which are thought to originate from the upper GI tract. Most of the geriatric population in their geriatric age group, they, in some time of their geriatric life, they suffer from these dyspeptic problems. So functional dyspepsia in Rome 4 criteria, that is one or more of the following, like bothersome postprandial fullness, bothersome early satiety, bothersome epigastric pain or bothersome epigastric burning sensation with no evidence of structural disease that is likely to explain the symptom, and that makes marked reduction of their quality of life. We all know about the general dyspepsia, which are the causes like food intolerance, tomatoes, spicy foods, excessive alcohol, fatty foods, coffee, and for other GI disorders like peptic ulcer disorder, non-ulcer peptic disorder, GERD, acute gastritis, non-ulcer dyspepsia, gallstones, or IBS. But in case of geriatric people, especially from North India, it is more fascination to have milk or milk product diet regularly. What the other causes of dyspepsia in case of elderly people? It's the drug due to polypharmacy. The main culprit is non-steroidal anti-inflammatory drugs, iron, corticosteroid, dioxin, theophylline, oral antibiotics, quinine, all these. Thereafter comes the mental status, the psychological problem like anxiety disorder and depressive disorder. And there are higher chances than the general population, that is the gastrointestinal cancers, the pancreatic enzyme deficiency or hepatic disease like hepatitis or hepatitis. And there are some other areas like renal failure, thyroid disease, or hypercalcemia. Apart from this acid and pepsin, there are the other causes important for geriatric population, that is impaired stomach accommodation and or emptying. There are some food allergies, H. pylori infection, and visceral hypersensitivity or psychological factors. For functional dyspepsia in elderly, it can be mainly from peptic ulcer disease, non-ulcer dyspepsia, H. pylori infection, GERD, functional heart burn, or SJMCH gastropathy. These functional dyspepsia are in two types. One is epigastric pain syndrome, that is pain in the upper abdomen with burning sensation, or that may be postprandial distress syndrome, that is symptoms like early fullness, bloating, or nausea. Why geriatric people common for this dyspepsia? Because they don't have the adequate chewing issues. They have inadequate chewing, ill-fitted teeth, or tooth loss. They have absence of physical activity. They have life changes like smoking, alcoholism, irregular eating, overeating. They have decreased production of the saliva, gastric juice, bile enzymes for digestion. They have psychological factors like anxiety, depression, mainly due to serotonergic activity lowering, and definitely polypharmacy. Most of the geriatric people are with minor polypharmacy, that is 3 to 5 drugs they are regularly taking. And gas producing problem in case of geriatric population is very common, and that leads to dyspepsia. Why this is? Because the food remains in the GIP for a longer time. The stomach is less with the acid needed for the digestion. The lack of digestive enzymes, there is loss or lowering activity of the GI tract muscles that fails to propagate the food from mouth to anus. There are certain medications that do constipation or blocking. There is regular intake of dairy products where there is lack of this lactase, or there may be some direct lactose intolerance. So while evaluating dyspepsia, we must give some time for the first visit of the patient. We must evaluate the patient's lifestyle. We must evaluate the patient's medication history. We must examine the patient carefully. We should note the psychological status of the patient, and we should look for the alarming symptoms. Alarming symptoms can come left. Some symptoms can give us the clue. Where is the disease? Where is the differential diagnosis of dyspepsia lying? Like heartburn, regurgitation, chest pain, maybe GERD, gastroesophageal reflux disease. Urinophagia, dysphagia, globus sensation, maybe due to malignancy or maybe obstruction, or maybe the non-malignant causes, even the psychological causes. The pain periodicity, fluctuating pain periodicity can differentiate it from the malignancy and mimics to the peptic ulcer disease. The location of pointing sign in the epigastrium or in the duodenal point, that can give us the clue that there is some problem in the acid peptic activity. And the timing of the day, mainly before breakfast or 3 hours after lunch, that is more prominent, and relief with food or antacid. We must evaluate the metabolic activity like diabetes, hypothyroidism, both causes gastropathy, and this gastropathy lowers the digestion system and the movement of the digestive tract. There is hyperthyroidism rarely, but it occurs, and hyperparathyroidism. And in case of renal failure, there is more blood with the creatinine and other excretin products. There are some other problems of the metabolism that leads to the protective mechanism lowering, that is when the GI gastric mucosal lining is getting delayed generated, and there may be the stasis or loose motion or indigestion. In most of the cases when dyspepsia is presented, there are other functional GI disorders that are overlapping, like functional dyspepsia with gastritis, functional dyspepsia with GERD, functional dyspepsia with IBS. So this is my suggestion, not to have much time to elaborate, but always go for the known 4 criteria of functional bowel disorders and get the clue which points are matching with the functional dyspepsia along with the other functional disorder, and you can get the actual diagnosis with the overlapping syndromes. What are the alarming features for dyspepsia? We should look for unintentional weight loss. We should go for dysphagia, urinophagia, unexplained iron deficiency anemia, persistent vomiting, palpable mass or lymphadenopathy, or in some cases family history of upper gastrointestinal cancers, mainly in the first degree relatives or second degree relatives. So while evaluating the patient of dyspepsia for the actual underlying disease, we should go for complete blood count, liver function test, pancreatic enzymatic function, diabetes, thyroid function test, serum calcium level, iron level, or serum LDH, to see the hypermetabolic state, may be benign or may be malignant, into the body. Upper GI endoscopy is a must when a geriatric patient is coming with dyspepsia, and H. pylori test is a must, because in most of the cases there may be much higher possibility in the geriatric population than the normal population to have some pathology like esophagitis, strictures, Barrett's, or cancer. When to suspect for esophageal manometry? If GI endoscopy is normal, esophagogastroduodenal scopy is normal, then if there is suspected achalasia, if there is diffuse esophageal spasm, scleroderma, non-specific motility disorder, then then go for manometry to evaluate the patient. Or phenixmetry is needed when there is intractable esophagitis, Barrett's epithelium, to assess the benefit of the medical therapy is needed, or atypical symptom of GERD with esophagogastroduodenal scopy normal. Regarding management of the dyspepsia, it's very important that two ways of management, both together or separately. But the most important management which we always miss or always fail to compel the patient to undergo, that is the lifestyle modulation. And for therapeutically, medical therapeutics, we can use antacid with alginates. We have H2 receptor blocker, Ppis, prokinetic drugs, and antidepressants. So regarding the management of geriatric dyspepsia, non-pharmacologically is first thing we should advise that do regular exercise that will improve your physical or mental health both. You can do walking, very light jogging, yoga, smooth cycling, swimming, behavioral therapy, or acupuncture. But remember, most of the geriatric population, they think that exercise should be done in the morning time without having anything or having 2 glasses of water. That is the wrong thing, because we have to get some solid food, light breakfast, and give a pause of 1 hour, then we should do exercise. Otherwise, the dyspepsia will increase just because there will be the accumulation of basal acid output in the morning and a high accumulation of the basal acid, as well as if we stretch the stomach with some large amount of water, that will increase the more acid secretion into the gastric area, and that will lead to more dyspeptic problem. Again, light jogging is needed. Strenuous exercise for geriatric people, that will lead to dyspepsia also. Cut down your tea, coffee, cola, alcohol. Rise your head and shoulder from the head end, that is from waist to head, that should be elevated. In case of where there is the regurgitation, nosocomial pneumonia, or there is intractable GERD, at that time, in Indian scenario, simply put 6 inches blocks, 2 blocks at the head and pedals, or you can use the wedge mattress of 6 inches height. Left decubitus position may be helpful for regurgitation who are vomiting or having nausea. Lose your weight, definitely you lose your weight. Overweight can lead to GERD more and dyspepsia more. And frequent monitoring of your serum electrolytes, that will help you to manage your dyselectrolytemia and dyspepsia in that manner. So what should be advised in that aspect? That is, take small but frequent meals. Avoid dining outside in the restaurants and hotels frequently, because the food quality and additives can do harm for the geriatric people. Avoid certain foods like FODMAP foods. Coming to the FODMAP, I think most of us nowadays know about the FODMAP, that is fermentable oligomono diatypical polysaccharides that produces more gases. And regarding the behavioral therapy, not to go for this, I think psychologists or psychiatrists will differ from that, but in case of gastrointestinal problems, we have seen in Indian scenario that there are some practices like meditation. There are some practices
like mindfulness that has come to the psychiatry from the Buddhism. The mindfulness is concentrate to what you are seeing just now in the present, concentrating to your present, whatever you are seeing, whether it is pleasant or unpleasant. You must not have some fluctuation of your mood to elated or depressed. That is a practice taken into the psychiatry from Buddhism. And for Western people, there are muscle relaxation technique, that is 28 muscles of our body we can contract willfully. We can feel that it is contracted fully and we are relaxing that. You can have very good videos in your YouTube for that. That can be practiced. So don't eat within 2 hours before going to the bed. Don't get rich spicy food. Avoid painkillers or NSAIDs as much as possible, or optimize the dose of the painkillers. Do not smoke. Avoid the over-the-counter drugs, and avoid alternate medicine given by your local unethical experts. We have the pharmacological therapies for PPIs, H2 receptor blockers, antacids. We can have Prokinetics or acetylcholine esterase inhibitor. Basically, H2 receptors were practiced for a long time since I was born. It was introduced into our medical science. It manages only the mild to moderate GERD or dyspepsia very well, but its long-term therapy, I am taking just 2 minutes. But when proton pump inhibitor came, the scenario totally changed because of its more efficacy and lesser side effect. There are so many trials which shows this proton pump is better, that is not. But remember, pantoprazole and rabeprazole both are equivocal in terms of their activity, efficacy. But pantoprazole has established its role for a longer duration therapy, more than 5 years also, because which people are with blood thinner like aspirin, they can have this pantoprazole for a longer duration to prevent dyspepsia. But in case of rabeprazole, it is lesser cardiac side effect is there. And pantoprazole has only one drawback, that is its onset is late. It takes much longer time to have its mode of action to get. But in case of rabeprazole, it is very quick. Antacid gives prompt relief from this acid and elevating the pH, but the main drawback of the antacid is it cannot be given regularly, just because there will be rebound acid reflux, there will be rebound acid secretion there. Sodium alginate with antacid has some additive advantage, because sodium alginate will protect the lower gastroesophageal sphincter and the fundus of the stomach from the acid harm. Prokinetics have much better action with increasing lower esophageal sphincter for preventing regurgitation, as well as it promotes the gastric emptying. Among the all prokinetics, levosulfide is better. It has a very good action and it has an addictive nature for the geriatric people to have this in case of dyspepsia. But nowadays, the prokinetics are added with PPIs, and these prokinetics with PPI will reduce the acid secretion, and prokinetics will promote the acid propagation from stomach. So there is additive action for prokinetics with PPI is there. But we must remember, must remember the side effects of PPIs and prokinetics. In case of PPIs, geriatric population are more prone to the cardiac arrhythmia. Geriatric population are more prone to nosocomial pneumonia. Geriatric population are more common to the osteoporosis and myopathy, and the vitamin B12 and hypomagnesemia, vitamin B12 deficiency. In case of prokinetics, if we use it more than 6 weeks, there may be sudden cardiac arrest or death, or there may be mild action like nausea, diarrhea, all these. But auxiliary syndrome or the pseudo obstruction of the GI tract can occur more frequently in the geriatric population. H. pylori is another important thing where the functional dyspepsia should be managed, because you always remember most of the geriatric population are having antral gastritis, and there the most people are harboring the secondary infection of H. pylori, and this stimulates the T cells of the antral region that will secrete more gastrin, and there will be more acid secretion. So what we should do is in H. pylori infection, we should go for non-metronidazole combination triple therapy. If this triple therapy fails, we can add colloidal bismuth for the quadruple therapy. If that also fails, we can try for furazolidone, tetracycline or rifampicin. So how to fail, I don't have the time to discuss, and how to detect the failure. Acoshamide, when it was evolved, people thought that that is the best drug for functional dyspepsia, but it's not for geriatric population, because acoshamide has the cholinergic side effects, and these cholinergic side effects are not acceptable for geriatric population. Another two drawbacks are acoshamide takes at least 2 weeks to have its onset of action, and it longer therapy for 3 months, and thereafter when stops, then acosamide's duration of the effect loses within 2 weeks. So acosamide is not the drug of choice of dyspepsia for geriatric population. For reflux inhibitor or antispasmodic, you can give baclofen or any other GABA agonist that can give you the short-term relief of pain or the spasm or the reflux, but it cannot be used for the longer duration, or your action will be vanished whenever it is stopped. It's better to come to tricyclic antidepressant and SSRI, as the serotonergic activity is lower. The most of the geriatric populations are suffering from anxiety and depression. The rule of thumb is, when the patient is more diarrhea prone, give tricyclic antidepressant, and if the patient is more constipation prone, that is the most common, you go for SSRI, and don't go for the word that is low dose antidepressant is needed. You start with low dose, but whenever it is needed, you can give the higher doses. You can change the dose to the higher level every week until and unless your optimized activity is reached. Sometimes phytotherapy is also. Sorry, I'm concluding. Sometimes phytotherapy is also available, and it is something relaxing for the geriatric people, like tulsi leaf chewing or peppermint, that gives some relief of dyspepsia. And sometimes dyspepsia can have some other associated symptoms, which relieving those symptoms can give the relief of dyspepsia, like constipation, diarrhea, blotting, flatus, or postprandial.
Dr. Ghosh, sorry to intervene. You are a super specialist in GI system, so you have taught us many things. So very simple things I'll tell. There are 3 parts in geriatric dyspepsia. There are 3 parts in the body, and the summary is that geriatric dyspepsia or indigestion is the commonest symptom in elderly. Is the commonest symptom. So any elderly on the road, so if you ask them, they tell, I have this bloating, I have badahajmi, or I have indigestion. So there are 3 parts. So this is the senescent of the GI system. Senescent of the GI system means the first system is the mouth cavity, as you have correctly told. It's the mouth cavity, and that is the dentist lookout. And implantation, RTI, root canal treatment, they are highly costly for our elderly. And so that is about mouth cavity, atrophy of the gum mucosa, epithelial atrophy of the mouth cavity, and the last part of the intestine, that is the large bowel. So large bowel plays a lot of role causing constipation. constipation we are discussing and eye infection is very or the commonest cause of dyspepsia in the elderly. And many elderly get constipation and the largest system of intestine, that is the small bowel and others, the longest system. We cannot do anything as you are telling. So any drug you told has a side effect. You tell PPI, gastric cancer. You tell prokinetic tremor, Parkinson. So any drug you are telling that they are habituated to that, they stress on taking that and they go to side effect. So the largest part need enzyme supplementation. Because of the senescence of the enzyme secreting system, they need enzyme supplementation. So take care of the mouth cavity, take care of constipation and supplement enzyme. So take care of non-drug measures for dyspepsia, actual dyspepsia that you are discussing very nicely. Thank you for your talk.
Just a minute, because dyspepsia is so much important in elderly. Every patient of elderly patients follow dyspepsia. And dyspepsia should not be taken as a lightly in an elderly person, because you must do upper Gi Endoscopy if the patient is having dyspepsia. Because sometimes 10% patient may be having gastric cancer. Then second thing, you do the pancreatic enzyme serum lipase and amylase, do an ultrasound or a CT imaging of the pancreas. There may be pancreatic cancer. And if the patient is having dyspeptic symptoms, as Dr. Mahara tells, many people are suffering from chronic constipation and mostly of not taking food on the next day as it is. Unless I pass motion, I will not take food, they will tell their children. So gradually they are having loss of weight. If there is a loss of weight in a person of elderly, then do a colonoscopy. It is a must, because most of the time you do everything will be normal. And the patient will tell, I am normal. But he has left colonoscopy as it's a difficult thing for him. So do colonoscopy. I found lot of patients having nothing in the blood examination, ultrasound and everything, but thinking that do a colonoscopy, there is a colonic cancer. So take these things in mind. Don't dispose dyspeptic symptoms with a PPI. And do a H. pylori test in every patient doing the upper Gi endoscopy, because that will eliminate the chance, or if it is there, you eradicate it, or otherwise in future you will go into the gastric cancer.
I think, sir, that I have covered all the points.
Yes, you have nicely covered, but I am stressing the main points.
Definitely.
With our physicians and the elite population here will take it, which is important.
So,
Thank you.
should I conclude in 2-3 slides?
You are always overtime.
I started it also.
Let me not neglect our madam.
So, if there is some anti-reflux surgeries needed, then remember there were conventional surgeries like mission chondroplication and Pins procedure, gastrosplexy, all those were there. But nowadays in geriatric population, it's best to do the endoscopy, radiofrequency ablation surgery, RFA surgery for least minimal endoscopic surgery for the geriatric population. So to conclude, if you get one patient of dyspepsia for elderly, always do one upper GI endoscopy with H. pylori test, and if there is any minimal mucosal change, do one histopathological biopsy also. If there is any organic disease you can find, go for the specific treatment of that. And if there is H. pylori positive, do treat the H. pylori for 2 weeks. Triple therapy is a must. Don't go for 7 days or 10 days therapy. And the success of H. pylori therapy you can assess after the 6th completion of 6th week from the starting of the 2 weeks triple therapy, and there you do a simple rapid urine test there. If these you find that there is H. pylori negative, you can give proton pump inhibitor for 4 to 8 weeks, not more than that. And you just assess whether after 4 weeks you assess the patient whether the patient has recovered from dyspeptic syndrome minimally or not. If no, then try for the antidepressant therapy. And if there is persistent symptom, you discontinue tricyclic antidepressant and go for one PPI along with one prokinetic drug for 4 weeks. And thereafter, if the symptom persists, then re-evaluate the patient from its lifestyle, its medication, its all surrounding activities or comorbidities, and then treat accordingly. Thank you for giving me such time, extra time for completing this presentation. And now I request our...
Thank you, Dr. Soumik. You have given excellent presentation. Thank you very much.